We're going to see some anatomical regions of the lung, diaphragm, and pleura. So here we have a lung, another lung. This is the right lung, this is the left lung. This is the trachea, the mainstay bronchi. We have two mainstay bronchi, the right and the left. These mainstay bronchi divide into secondary bronchi, which are three for the right lobe, three for the superior, middle and inferior lobe, and two for the left lobe. And then each of these divide into tertiary bronchioles or segmental bronchioles. First, in this segmental bronchiole, we have the bronchial artery and branches of the pulmonary artery. Each of these are coming to it or along the tertiary bronchioles, and in the alveoli, the branch of the pulmonary artery becomes capillaries, and we have the interchange of gases, and the bronchial artery gives blood to the lung and then returns for the bronchial vein, which drains into the pulmonary vein, in the small pulmonary veins. So that's because we have a little bit of deoxygenated blood coming to the left atrium. All right. Next point is the relationship between the pulmonary artery and the mainstay bronchi. We have the pulmonary artery that divides into two, the right and the left. The right pulmonary artery here is anterior to the mainstay bronchi, and the left pulmonary artery is superior to the mainstay bronchi. Alright, now the pleura. We have the visceral pleura that is here just surrounding the lungs, and the parietal pleura. The parietal pleura is touching the walls. The walls could be the diaphragm, so we have intercide. So here is the diaphragmatic part of the parietal pleura. Then here is the mediastinal or central part of the parietal pleura. Here is the cervical part of the parietal pleura, or is the cervical parietal pleura, and here is the costal part of the parietal pleura. When we have the reflection of the parietal pleura and change in direction is abrupt, the change in direction is, for example, here between the costal and diaphragmatic parietal pleura. Here we have a recess. This recess is called the costodiaphragmatic recess, and we usually should see it in the chest radiograph, but it could be blunted, or we could not see it in emphysema or pneumonia because of the pleural effusion. Okay, and this was the pleura. Next, how we are going to listen the noises of the lung, the breath sounds. These are, if we want to listen the superior lung, let's say in the right lung, if we want to listen to the superior lobe, we put the stethoscope in the fourth rib, a little up here, a little up of the fourth rib for the superior lung. For the middle lung, we put the stethoscope a little below the fourth rib, and if we want to listen the inferior lobe, we put it posteriorly, not anteriorly, instead posteriorly. Next, the sides of the thoracentesis. This is intercostal space and line. So it is the intersection between some intercostal space and some lines. Intercostal space, it could be between the 6th and 8th, between the 8th and 10th, and between the 10th and 12th. Between 6th and 8th intercostal space would be in the mid-clavicular line. Between the 8th and 10th intercostal space is in the mid-axillary line. And between the 10th and 12th intercostal spaces is in the paravertebral line, so it could be posterior. And usually we do the thoracentesis above the inferior rib of the intercostal space, because we have the rib in its inferior border has the vein, artery, and the nerve here. So if we are in the, let's say, 8th space, we are going to do it here, superior in the rib, because if we do it here, we have the risk of damage these vessels and the nerve. So we do it in the superior border of the inferior rib. Alright. Next is the diaphragm. The diaphragm has three hollows. The most posterior is for the aorta, and this is the hiatus of the aorta. Through this hiatus passes the azygos vein and the thoracic duct, and obviously the aorta. Then we have the inferior vena cava. The inferior vena cava passes through the central tendon of the diaphragm and the aorta. And this hiatus of the aorta is along the arcuate ligament. Alright, and this is for the esophagus and the vagus nerve. The intercostal or the vertebral level at which we have this foramen is for inferior vena cava. It is at the 8th vertebra. In the esophagus it is at the 10, and aorta is at 12. So we can say I 8 X at 10 o'clock. So I 8, this is sounds like 8 X esophagus at 10 o'clock. So I inferior vena cava 8 X esophagus at 10 o'clock 12 at aorta o'clock. So this is esophagus with 10 and aorta with o'clock of 12. Alright. This was for the diaphragm. Now the muscles of respiration. Inspiration is passive. Inspiration is usually in normal conditions, in resting conditions, is just of the, well, certainly the diaphragm is the most important, and then the external and internal intercostals. The internal intercostal is the interchondral part. Expiration is passive, and in exercise or with forced musculature, or when the patient is in respiratory distress, here we have the same, the diaphragm, the external and internal intercostal muscles, but also the sternocleidomastoid and the scalenes, anterior, medial, and posterior scalenes. And for expiration, we have the abdominal muscles, the internal, external, and transverse oblique muscles, the transversus abdominis, and the rectus abdominis. So internal, external, oblique, transversus and rectus abdominis. And the intercostal, internal intercostal muscles, but instead of the interchondral part is the interosseous part. Alright, this is for muscles of inspiration and expiration. And now the aspiration. Here we have the right lung, the left lung, the trachea, the bronchi, the mainstay bronchi for the right is wider and more vertically than the mainstay bronchi for the left. The angle is more horizontal, more like this, and it is narrow. So if we aspirate something, it usually goes to the right lung. And exactly in which part of the right lung, it depends on how is the patient, if it is upright, if it is in the cubitus supine position, or if it is in the right side, for example, lying in the right side or lying in the left side. If it is lying in the left side, well, it could go to the left lung. If it is lying in the right side, it would be to the lower lobe of the right lung. Now, if we are in the upright position, it goes to the posterior basilar segment of the lower right lung. And if we are in the supine position, this can go to the posterior segment of the upper lobe, or could go to the superior segment of the lower lobe.